Hello, my name is David Murray. I'm the Associate Director for Prevention and the Director of the Office of Disease Prevention at the National Institutes of Health. I'm pleased to welcome you to the second of three 2024 ODP Early Stage Investigator Lectures. We created this lecture to highlight early career prevention scientists who have not yet served as a principal investigator for a substantial NIH-supported research project, but who have made outstanding research contributions to their respective fields and are poised to become future leaders in prevention research. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the chat pod. You'll need to open the pod by hovering your cursor at the bottom of the Zoom window and then clicking on the chat icon. Please direct your questions to hosts and panelists. We will open the floor to questions at the end of the lecture. The slides and video recording will be posted on our website in the coming weeks. We're excited to present one of our 2024 awardees, Dr. Jessica Perkins. Dr. Perkins is an assistant professor at Vanderbilt University's Peabody College of Education and Human Development and serves as core faculty at the Vanderbilt Institute of Global Health. Dr. Perkins' research in rural Uganda focuses on social norms and health outcomes among adults in an ongoing network cohort study. Additionally, she assesses structural and social determinants of stigma and HIV prevention and treatment in Tennessee using community-engaged mixed methods. She also studies health-promoting social norms among adolescents and young adults across the United States. Dr. Perkins will describe misperceived HIV-related norms and why these misperceptions matter for multiple levels of HIV prevention. She will also discuss developing interventions to harness perceptions about existing protective norms to enhance the uptake of HIV-related health behavior interventions. Please join me in welcoming Dr. Perkins.
Hi, everyone. I'm really excited to be here today. And I thank everyone for attending this morning. And for those who log on in the future, I look forward to sharing some of my work with you as you watch the recording. So to get us started for today, I just want to say that I don't have any conflicts of interest, and I am funded from a K01 through the NIMH and also through a Development Corps Award through the Tennessee Center for AIDS Research. And I have many people to thank who I work with in collaboration, and I will hopefully get a chance to name all those folks at the end of this talk today. So to get us started, I always like to center my talk and my program of research around some of the big overarching questions that guide my work and sort of guide my motivation for doing what I do. And I have a sense that most of the time, these questions are driving a lot of folks. And so they are, one, what factors drive human behavior, health outcomes, and health disparities? I think a lot of us are trying to answer those questions, and then to think about how do we take that information we learn about those factors and design interventions? So where and how can we intervene and improve prevention-related behavior and ultimately individual and population health outcomes? And then we move on to think about what doesn't work and what might work. How can we adapt successful interventions and strategies? And how can we do so in a way that increases health equity? And so those ultimately are my overarching driving questions. And I think that could resonate with a large swath of folks. And I put those out there too, for anyone who might be sort of in the early stages of their training. You may not be able to articulate what it is that drives you at this moment, but I promise you eventually at some point, you will be able to do so. I also like to share a little bit about my background when I'm discussing my research, because I think I really sit at the nexus of several disciplines. So in my early days as an undergraduate student, I did a lot of work in psychology. I have a degree in psychology. And then I eventually moved on to study and work in public health, and particularly in global health. And then I ultimately did a doctoral degree in health policy. And so I went from Davidson College in psychology through Harvard University, and then ended up really deciding that I was really interested in prevention, and did some postdoctoral work in population and global health at the Center for Population and Development Studies at Harvard, and then at the Center for Global Health at MGH. And I have a lot of folks to thank along the way who guided me in that pathway. And I have this picture up there, this sort of road making in progress that's winding through some mountains in Uganda to indicate that it's okay if you don't know where you're going or necessarily where you're headed, but ultimately that thread, that programmatic thrust, that pathway will show up for you as it did for me. And it has culminated in where I am today as an assistant professor in the Department of Human and Organizational Development at Vanderbilt. And I'm also core faculty at the Vanderbilt Institute of Global Health. And my work has really sort of come together and culminated in conducting interdisciplinary research and applied scholarship, often working with my doctoral students in their PhD program in community research and action. And I collaborate with folks across psychology, medicine, economics, sociology, anthropology, geography. And so I really like to think about how the work that I'm going to present today can be of interest and applicable to folks across all of these types of disciplines. And so digging a little bit into my program of research, I always like to offer a sentence or two that describes why I do what I do and what continues to motivate me. So here it is, the current version. We are all inherently connected to a vast network of people from which social norms arise and drive our attitudes, intentions, and behaviors. And we can't escape that. These networks and norms influence us across multiple levels, whether it's at the individual level, whether it's in dyadic interpersonal relationships or within our communities or the broader society. These networks and norms influence us across multiple levels, whether we are consciously aware of it or not. And so I study social norms and health outcomes in part because I think they're such a critical, universally important phenomena that drive a lot of our decision makings and behaviors. And we can look at this from a lot of different angles, but it sort of comes up as an important driving factor across cultures and populations and contexts. So today, I'm going to give you a brief introduction into how I take that perspective, that lens, and look at HIV prevention and treatment with some specific examples arising from our empirical ongoing cohort study in Uganda, and then thinking through how we can use what we've been finding to design, enhance, and adapt some prevention programs that are addressing misperceived norms to think about how we can improve the uptake of what we know to be effective interventions around HIV prevention and treatment. Okay, so first I'm going to introduce, just very briefly, to get us all on the same page, the current context of HIV prevention and sort of where do we stand, what progress has been made. So first, we know we have really good primary prevention and treatment interventions. We have drugs and medication like PrEP. We have a variety of different kinds of ART therapies, whether they're pills or injectable forms. We have HIV testing that we know that works. It can be done in a clinical setting. It can be done at home. We have other intervention strategies like uptake of male circumcision. And many of these kinds of interventions are effective in reducing the risk of HIV transmission. And they are accessible and affordable to some degree for most people. So we have these interventions that work. Okay, so given that context, sort of we want to ask the question, well, where do we stand in terms of uptake of a lot of these interventions? First, we're going to step back for 1 minute and say, well, okay, what are our thresholds? What are we trying to hit? Well, in 2014, the Joint United Nations Program on HIV/AIDS launched the 95-95-95 targets, where we are trying to get 95% of people aware of their HIV status, so getting them tested. And in HIV endemic areas, that means testing pretty frequently, for example, once a year. And then among those people who are diagnosed as living with HIV, then we're going to try to get more than 95% of them on treatment. And then of that group, we want to get at least 95% of them to be virally suppressed through antiretroviral therapies. And so that's our target. And so again, we have these effective interventions. We know what our targets are. We know what we need to do. But unfortunately, despite lots of effort and time put into a variety of strategies, which do work, there's a lot of mobile testing interventions. There's a lot of affordable care out there. We're trying to address structural barriers. There's a lot of great programs trying to address stigma around HIV. There's still a large group of people who are either unaware of their status or who are not taking treatment regularly. And so we still have work to do. For example, in 2023, more than 1 million individuals acquired HIV, and there are still more than 500,000 of folks dying from HIV. So there's still really critical work to do around HIV prevention and treatment. And so that's where I've come in thinking, okay, what are some areas that we haven't yet fully explored in terms of how we can be creative in terms of designing interventions and strategies to help end the HIV epidemic? And so when we look at these challenges and hitting the thresholds, and we're thinking about the 25% of folks who don't know their status or are not taking their medications, it suggests that behavior in part does matter. So what can we do about that? I like to share this quote, and this was from the World Development Report in 2015, where it sort of squarely hits on a really important point. Individuals are not calculating automatons, rather they are people, and they are malleable and they are emotional actors whose decision-making is influenced by contextual cues in the environment, by the local social networks we are in and the social norms that arise out of those networks, and our shared mental models. So we are driven by many more factors than we are necessarily aware of. And so in addition to addressing critical structural and social determinants of health, like access and quality of care and education and resources and information, we need to be thinking about how we can help end the epidemic using behaviorally informed, evidence-based programs. And so this is where my work steps in to think about, well, let's take a look at the importance of social norms as root causes of attitudes and behavior, and how they might drive some of the decision-making and ultimately the behaviors that people engage in around HIV prevention and treatment. So a few minutes on social norms, just to get us all on the same page. Generally, when we hear the term social norms, and it gets thrown around a lot in research and literature and on social media, you might see it anywhere. We kind of have this general understanding that social norms are understood as these unspoken rules in our community, in our society, in our workplace contexts, in our schools, about how people should behave in any given situation. So for example, how do we behave when we enter a restaurant? Or how do we behave when we enter a health clinic? Or how do we behave within our community settings, perhaps at a wedding? How do we behave when we're out socializing? And we know that the social norms around us that we perceive to be out there in our local environments, they affect us. They drive our behavior. They tell us to say something and speak up, or they don't. They tell us to engage in a certain behavior, or they don't. But one of the critical questions around this is, well, how do we know what those norms are? Because a lot of the times, again, these are unspoken rules. They're not written down. So what do? Often, we look to others and those around us to know how to act. So when we enter into a given space, we unconsciously or consciously look around to see what others are doing. How are they acting? And you can sort of look this up on the internet. You can look at social conformity videos on YouTube. A lot of them are quite entertaining. And you can see that people sort of fall in line, figuratively and literally, in terms of what other folks are doing. And so we take these environmental and social cues, and it ultimately ends up driving our behavior. And there's lots of different kinds of cues in the environment that contribute to our understanding of what the local social norms are. So what turns into policy and law, that can drive our idea of what the social norms are. What we talk about in conversation. So if we talk about, oh, so-and-so was doing this, or all of my friends were doing that, that sort of informs what we think are the typical behaviors in our important peer reference groups. What we see, and often what we see even just one time, we end up interpreting it as a social norm. What we hear about constantly in social media or in the news, or perhaps what our parents talk to us about, or what we see celebrities and role models doing. We take all these pieces of information, these social and cues in our environment, and they ultimately help us form what we perceive to be the social norms in our context. And the reverse is also true. What we're not seeing in these spaces in our environment also contributes to what we perceive to be normative in any given situation. And so if folks aren't talking about a behavior because it's stigmatized, or if it's just kind of typical normal, for example, I don't know, folks trying to get a good night's sleep, we don't often talk about that. Rather, we talk about how much sleep we don't get. And so the sorts of conversation we have around what's extreme, we often talk about what's extreme and what we see in the news, that informs our idea of perceived social norms just as much as what we don't talk about. So this brings to light two questions. First, does our understanding of local social norms represent reality? Are we good at knowing, actually truly knowing, what is the typical common behavior among our peers or in our local community, among those who are important to us? And so it creates this research question where we are looking at two different norms. We can separate social norms into these two groups. First, we can think about a perceived norm, and that is what an individual thinks most people in a group do or support. And then we can think about, well, does that match what the actual norm is? What do most people in that group do or support? And this brings us to the next question. Well, if people's perceived norms don't always match reality, do those misperceptions matter? And so an example of a misperceived norm is, I think most people do X, when in reality, most people do not do X. And is my misperception driving my personal outcome, my personal behavior? If I think most people are going to engage in a lot of alcohol consumption, for example, and a lot of this work was founded in that field, then do I ultimately engage in more alcohol consumption? Do I support others to do so? Do I tolerate others to do so? So that's kind of the overarching conceptual framework regarding the role of social norms and breaking it down into thinking about perceived norms versus actual norms and what ultimately drives, in part, our behaviors related to health outcomes. And so today I'm going to talk a little bit about misperceived norms and HIV-related transmission risk and prevention behaviors, and how we have some evidence, some empirical evidence from whole population network studies in rural Uganda that indicate, yes, pervasive misperceptions exist and they do matter. And then we are thinking about, well, what can we do about that and how we can design some HIV prevention programs. So the data are from a longitudinal cohort of adults across 8 villages in Southwest Uganda that we started in 2010. So we got together the local leaders and we said, we're really interested in looking at social norms and community behaviors and individual behaviors broadly around HIV and a number of other health outcomes. And we sort of dug into these questions in a community engaged fashion way. And first we measured the networks of everyone so we truly could know what are the actual norms in these communities. And then we also started to ask, well, what are the perceived norms? So again, going to that first question, let's separate out these types of norms. And so, for example, we asked everyone individually, how many men and or women in your own village do X? So for example, get tested for HIV, are interested in taking PrEP, would support others to get on PrEP or to go for male circumcision, questions like that. So sort of their idea of how many others they thought did this. And then we actually measured the prevalence of these behaviors and these supports in each of these villages, and we compared them. And so we could look at, to what extent do misperceptions arise? And ultimately, we have found pervasive underestimates of existing positive local norms for HIV testing, ART adherence, male circumcision uptake, and willingness to talk about and take PrEP. So in all these cases, the majority of people do get tested for HIV and do so pretty regularly. Among those who are living with HIV, most of them are on ARTs and most of them are adhering quite well. And the prevalence of male circumcision uptake is increasingly positive. And most folks are willing to talk about getting on PrEP with their spouse, with a healthcare provider, and with their friends. Similarly, but in contrast, we have also found overestimates of sort of these negative attitudes in HIV-related behaviors specifically around stigma. So for example, 2/3 of adults incorrectly thought that most of their male and female village peers had never been tested for HIV, even though most had been tested in their lifetime and in the past few years. Another example, 19% of circumcised men, 43% of uncircumcised men, and 47% of women underestimated the male circumcision prevalence in their village. They, for example, thought that 10% of men or fewer had done it, or they had no idea. But the reality was that almost half of young men are circumcised, and that prevalence has been increasing over time in the last decade. And again, another example of this misperception is that 1/3 of adults thought most men and most women were not willing to talk about PrEP with a provider, even though 3/4 or more of adults in their villages were willing to do so. Similarly, we have also found misperceived norms around other issues that are linked to HIV risks. So for around alcohol use, violence when thinking about partner PrEP use, and perpetration of intimate partner violence in general. So for example, 81% of adults mistakenly thought that most men in their villages drank heavily, even though only 1/4 did so. And again, 39% of adults mistakenly thought that majority of men would react violently to a partner if the partner took PrEP, even though 2/3 would not do so. And 45% of men mistakenly thought that most men endorsed intimate partner violence, and almost half of men mistakenly thought that most other men perpetrate intimate partner violence at least monthly, even though only 1/4 of the population endorsed the use of IPV and less than 1/4 perpetrated it at least once a month. So while these issues around violence and alcohol use and not getting tested for HIV, while they are important issues, we can also look at the flip side of the coin and say, hey, there's actually a lot of people doing sort of the health promoting behaviors, what we want to encourage people to do. And so there are these existing positive social norms in these communities. We can begin to ask the question, well, can we use that information to help people make decisions that would sort of guide increased positive behavior and create a social climate that would help them to do so? So in summary, if you missed all that, and you're only going to remember sort of one key point from all of that, here it is that these misperceived norms exist, and that people tend to incorrectly think that negative, unhealthy, and risk behavior and attitudes are common, when in fact, positive, healthy, and protective behavior and attitudes represent the majority. Okay, so now the question becomes, well, we know these misperceived norms exist, but in reality, do they matter? And do they matter given that we know that all these other factors matter when we're thinking about predicting HIV-related outcomes? So it's this question number 2, do misperceived norms matter? And do they matter when we're accounting for other sociodemographic characteristics, other HIV-related factors? And do they matter when we're accounting for what people's close network peers do too? Because we know that like being connected to people who are engaging in alcohol consumption or who might not be getting tested for HIV, that matters too. So to what extent do misperceptions influence behavior on top of all these other factors independent from them? And we have found over and over again that perceived norms about these behaviors are strongly associated with HIV-related behavior, even when accounting for all those other critical factors. So adults who misperceive positive local norms, that is, they don't think they're common, they themselves are less likely to engage in prevention behaviors, and they're more likely to engage in transmission risk behavior. And there's a few examples up here on the slide where we have found these findings that misperceptions exist and that they drive behavior, even accounting for peer behavior, other risk factors, other sociodemographic factors. We found this in relation to HIV testing, ART adherence, stigma, male circumcision, alcohol use, intimate partner violence, and willingness to talk about PrEP, as well as some other global health issues. So we see continuously that this phenomenon, this matters. Now, okay, that's with adults, and we're starting to think, well, we want to take a step back and say, okay, well, what does it look like among youth? And so from preliminary work that we've conducted, we know from some small cohort examples that up to 75% thought health risk behaviors like condomless sex, transitional sex are common among peers when in fact they are not. And among youth who misperceive these norms, they were more likely to engage in risk behaviors, for example, like transactional sex. We have a lot more work to do in looking at this among youth, but we have some preliminary data indicating that these phenomena are going to exist and that they're going to be important, and that we should be thinking about them in terms of interventions. Likewise, when we think about who influences youth, well, there's a lot of adults that are connected to youth that might influence them, whether that's parents or community health workers or local leaders, other folks that they look up to in their communities. And these folks are just as likely to misperceive these norms among youth. So for example, in doing some qualitative work with parents, we found that, they think that few young adults engage in behaviors like getting tested for HIV. But we know from our data that most of these young adults actually have been tested for HIV. But they think they fear testing and how society will treat them. And while that stigma is real and true, and we do need to be addressing it, The reality is that a lot of these youth are getting tested for HIV. And so how can we use that information again to sort of help motivate continuous uptake of HIV testing as frequently as recommended, and among those who have not done so yet? And again, community health workers and other kinds of local leaders also misperceive these norms just as much as other folks across these populations. And so it's, again, important to begin to think about, well, how these adults talk about what they perceive as social norms around HIV that could affect youth decisions or contribute to the stigma that arises around HIV-related topics. So all this work that we know in terms of answering these two questions, do misperceptions exist about HIV-related behaviors, and do those misperceived norms about HIV-related behaviors predict behavior, that novel work is building on a large history of literature, primarily coming out of the substance use, the alcohol and other drug fields, and mental health and sexual assault and violence. It builds on these findings about the important role of perceived peer norms and other behaviors in other contexts. And I've been doing work in this area for a while as well. I have some studies on substance use, some around gun violence, and some other topics that indicate this finding seems to be universal. Granted, there are caveats, and I can dig into those with folks at any point in time. But universally, it really signals we should be paying attention to social norms. And so taken together, these misperceived norms matter, and they create this harmful cycle. They do that by, first, when people think a risk behavior is the norm instead of a prevention behavior. They're likely to make choices that align with that misperception and engage in risk behavior. And then for those who are engaged in the health promoting behavior, but who think that health promoting behavior is not typical or normative, they're likely to hide or diminish their own healthy and protective choices, attitudes, and behaviors because they think they are atypical. And so then that health promoting behavior, for example, HIV testing, becomes more and more invisible to others. And then it's sort of in terms of like a community or collective impact, people are less likely to speak up when they witness others engaging in a risk behavior or making decisions that would lead down that pathway. And they might be more likely to tolerate or even support that risk behavior among others, because they think that it's typical and that others would support it as well. And so it creates this harmful cycle. And so what I like to think about is, well, how can we break that harmful cycle? How can we treat these misperceived norms as an opportunity rather than a problem? And again, going back to the literature for the last few decades, we know that perceptions, this is the good news about this, that they are malleable. And sometimes malleable in a way that is quicker than addressing other structural and social determinants of health in the meantime, which we should be doing as well. But that we can work on changing these misperceptions at the same time, because we have a fair amount of evidence now in other topics that shows that changing perceptions can change individual and population behavior. From folks such as Prentice, Miller, Cialdini, Ramal, Lipinski, Neighbors, Peterson, and many others working in the fields of alcohol and other drugs, environment-related concerns and behaviors, sexual assault, and civic behaviors. They've really grabbed onto the idea of social norms. And so that's what we need to do in HIV prevention and treatment research too. There's this opportunity to sort of think about, well, how can we take what we're learning about social norms in other fields and what we're finding in terms of this universal phenomena regarding misperceived norms and that they matter for HIV-related behavior. Well, how can we use that information to design new interventions and strategies to increase uptake of things like PrEP and HIV testing and circumcision and drive down stigma? So ultimately, it leads me to this conclusion that addressing misperceived norms that drive HIV-related behavior represents an area for growth and innovation in HIV prevention work. And it's an opportunity to promote uptake of effective interventions. And here's where we stand at the moment. There's just few behaviorally informed interventions like this that change perceived norms. Not many are utilized in the context of HIV prevention, especially in HIV endemic contexts, where sort of all hands on deck is important for getting us to ending the HIV epidemic. So this brings me to the next portion of this talk today, where I want to introduce you to thinking about how we can address and correct misperceived norms related to HIV prevention, given what we know. and then some future directions for where we might go with it. Okay, so here we go. One, if we know that misperceived norms are pervasive, and we've really started to build up that literature saying that these misperceived norms matter for youth in terms of HIV-related behavior. That's sort of a new area of work. And we based that on, we know that these misperceived norms around HIV matter for adults. Then how can we change misperceived norms about HIV-related behavior? And who's been doing what in this field around those questions? And so stepping back a little bit, again, we know that we can change perceptions to change personal and collective outcomes. And if you dig into the literature around this, you're going to find all kinds of terms, again, used to describe these interventions. So I'm just putting them out here for those of you that might go on to look at this. You know, some of these intervention strategies are referring to a social norms approach. Some refer to a norms-based approach, norms correction approach, a norming intervention, positive community norms. And what this leads me to say to anyone interested in these kinds of approaches is that I think it's really important to read interdisciplinarily, look across fields. I think reaching out to colleagues in other areas who are broadly addressing social norms to begin to think collectively together is really critically important when we're talking about social norms. And especially trying to get a sense of, well, what do we really mean? And for me, and for those working in the sort of addressing misperceived norms field, it comes down to separating out these types of norms into perceived norms versus actual norms, and looking at how can we address people's misperceptions. And part of doing that is really focusing on, well, what are the actual norms in these communities? And most of the time, the actual positive behaviors, the ones that we're interested in increasing, are typically normative. Most people are getting tested for HIV in a lot of contexts. Most people do support the use of PrEP. Most people do want to engage sort of in these health promoting behaviors, and they would support others to do so. So how can we capitalize on those existing positive norms to then encourage others, for those who are not engaging in that behavior yet? How can we use those existing positive norms to encourage others to do so? And how can we highlight those existing positive norms to help reduce stigma, to help bring about opportunities for positive conversation that more and more folks are doing this? So how can we change the overall climate when talking about these behaviors, instead of talking about doom and gloom and the extreme examples of like the negative behaviors that we might see in the media? How can we flip the statistics and flip the message to really say, hey, most folks are doing this, like I'm going to get in line with that too. And so the way to do that is simply tell it like it really is. Make those positive local norms more visible and salient in the local environment. And I'll talk about some ways to do that. And then the idea is that doing so ultimately leads to less exaggerated misperceptions of norms or total correction of misperceived norms. And that ultimately, that it motivates people to uptake healthier behavior attitudes, and it creates this increased support for health promoting behavior more broadly across the community. And a couple things to think about when sort of you're thinking about designing programs like this is that these messages need to be positive. Again, instead of focusing on sort of the negative statistic, we want to flip it and say, well, what is the good here? What are most people doing? And how can we create some messages that represent, you know, people across these communities in an empowering way? And ultimately, really importantly, they need to be based, these messages, they need to be based on credible data that's local and feels identifiable to the people that you're sharing them with. And then to share sufficient sort of messages around positive norms over time, and sort of perhaps group different kinds of norming messages together. And the idea behind this is that it's empowering, and it provides a sense of hope, and that it really focuses on the existing positive norms in a community, especially in places, for example, perhaps where there's not a lot of other infrastructure available in that moment. And I do want to stop and note and say that these messages do not prescriptively say what is good or bad about a behavior or health outcome, or what people should or shouldn't do. And they certainly do not come with scare statistics or fear-based imagery, because we know that that kind of communications is actually ineffective and may take away or even harm the kind of positive messages that we're trying to put out there. Okay, so once you've kind of thought about how to flip the statistic, well, how do we get those messages out there? And there's a lot of ways to do that. And so here are some terms that you again might see in the literature through social norms marketing, education, entertainment, small group discussion. You can see these positive messages within a network, send them out on text messages, create some games around it. But the idea is we want to get some of those positive norm messages around HIV prevention and treatment related behavior out there. So for example, here's an example message when delivering this kind of information. 75% of men and women in your village have been tested for HIV in the past few years. You could imagine having that on a billboard. You could imagine community health workers sharing that information. You could imagine that up on some kind of sign or display through a visual at a health fair that's providing mobile testing services. Same thing if we're talking about a different topic. For example, most men and women in your village would not beat their wife or partner if they found out that she or he was taking PrEP. And so that's another kind of message that we can begin to think about as we're trying to scale up the rollout of PrEP, whether it's through pills or in injectables. And again, another option for sharing those kinds of information is doing so kind of at a one-on-one level. And so you can think about sharing those messages at a population level through radio or through community health workers or small group conversation or billboards, but you can also have one-on-one feedback to folks that not only shares the positive actual health norm message, but also it tells them, well, let's help you think about this in relation to what you had thought and what your own behavior is. And that's called personalized normative feedback. So for example, you thought 40% of people in your village had ever been tested for HIV. So you thought most had never been tested for HIV. But the reality is 85% of people in your village have been tested for HIV at least once, and more than half have done so in the last few years. Now let's think about your own behavior. You last got tested more than 5 years ago. Would you like to get tested today? We have free services here. We can connect you to these HIV counseling and testing services. And so you can imagine how those kinds of messages can be incorporated into conversations in a variety of spaces and places. I also want to point out that there's some increasing new scholarship saying that, you know, for perhaps some things, for example, that are new interventions that the majority of a population might not have taken up yet, there are ways still to think about the role of social norms. And we think about that in terms of trending norms. So if there's an intervention that's starting to be increasingly used, that's a health promoting behavior, you can emphasize that increasing prevalence. So for example, the number of young men choosing to get circumcised here, for example, at this health clinic, increases every year and have support from their partners to do so. And we have found that in our villages in Uganda. Now, almost half of men aged 18 to 35 in your village are circumcised, compared to a quarter 5 years ago. Free male circumcision services are available here. And this could also apply to areas around PrEP. So for example, we know that more than 70% of married and single men and women in your village are willing to talk with a health provider about PrEP. More and more people in your personal social network every year are willing to take PrEP and think it would help them fulfill life dreams. So we can begin to think about how we can reframe the conversation, the statistics that are being provided around these positive local norms. And so that's kind of where we're at. And there are people that are getting excited and interested in testing these ideas. But so far, there's been pretty limited examples in HIV scholarship. And so there's a lot of opportunity for taking these phenomena and these concepts and applying them to HIV prevention. Some folks have thought about, well, displaying visual imagery outside a clinic regarding the number of folks that are on ARTs. So a tree with lots of leaves indicating that a lot of folks are on ART. Sending text messages to young adults about the ART positive adherence norms in their group. Conducting some personal normalized feedback about, hey, most people in this community don't stigmatize folks with HIV in the ways that you had thought. And then looking at, does that contribute to things like decreased sense of stigma and increased sense of HIV testing uptake? And then also some new work in South Africa, thinking about at the school level, can we help decrease things like intimate partner violence perpetration, because that's inherently risk to HIV, linked to HIV. And so can we do that by exploring sort of these positive attitudes around not engaging in intimate partner violence among youth and adolescents in schools? And so I'm going to go back to the title of my talk that said something to the extent of thinking about exploring misperceived norms as opportunities for individual and collective change. And so here I'm going to present the arguments for both sides of that change. So at the individual level, we can think about the potential effects of interventions that highlight actual positive norms and reduce misperceived norms. So one, that can motivate uptake at the personal level of prevention behavior. So if I had previously thought that no one got tested for HIV, and I now know that most of my peers are, and they're doing it pretty regularly, I might go do that too. For those of us who had that misperception, but who had been tested for HIV in the past, well, perhaps correcting that misperception is going to help me maintain that behavior. So I now may be more likely to get tested every year and to support others to do so and to talk more openly about my own HIV testing behavior. And then correcting these misperceptions broadly is going to inhibit the development and spread of these misperceptions. And it's going to perhaps help other folks to seek ways around existing barriers to engaging in prevention behavior. And at the community level, correcting these misperceptions, saying, hey, most people are getting tested for HIV, most people wouldn't stigmatize people living with HIV. It's going to continue to reduce the stigma that may be associated with prevention behavior. We know that stigma matters when we're thinking about how to get people to take PrEP or how to get people tested. So increasing these sort of positive ideas in the community about the prevalence of people engaging in protective behavior, that's going to help us reduce that stigma. And it's going to help others in terms of their willingness to be vocal about engaging in prevention behavior. And so if we can put these statistics into the local social environment where people look around them to figure out what are the social norms, that's going to create conversation around it. And people might be more likely to be willing to share their own stories about how they got access to something or who they went with and talk about it in their personal friendship networks. And again, this overall is going to help inhibit the spread of misperceptions. And ultimately, these effects may grow stronger and stronger as the actual prevalence and collective awareness of health behavior increases. And so there's this potential for these strategies that are going to help address misperceived norms and reduce them and ultimately correct them, to have both individual and collective effects. And ultimately, I want to say, and step back and argue, that changing misperceived norms ultimately perhaps should be and can be part of a comprehensive HIV prevention approach. This kind of strategy can certainly be done on its own, but it also might be most effective if it's paired with other strategies. For example, other kinds of education, entertainment, or new policies around free access to different kinds of care or testing, or around PrEP rollout. And so I encourage folks to begin to think about, well, how and where and when can we think about creating these strategies to reduce misperceived norms to increase HIV prevention uptake? And so first, we can think about combining strategies. We can use strategies that perhaps are targeted with populations that we know that might be at higher risk of HIV transmission. But then we can also have these communication strategies highlighting actual positive norms across the population, again, to help support a climate that supports uptake of HIV prevention behaviors and reduction of stigma. So using targeted and universal prevention norms change programs to change individual behavior and attitudes and lead to collective change. And then I think it's important to think about, well, there are certain people within our communities that people might look up to. There might be role models, local leaders, and it would be really important to help change the way they talk about HIV and related issues. So if our local leaders and community health workers or healthcare providers or role models or famous people are talking about it in negative ways, can we help flip the conversation for them? So changing their perceptions about local norms among key leaders and how they talk about these norms to combat the spread of misperceptions. And then ultimately, can we complement those strategies alongside policy changes, structural changes, and provision of other services? So that's kind of my argument around addressing misperceived norms and how we can enhance HIV prevention programming. There's still a lot to be done in terms of research and scholarship. So we need to be thinking critically about how we can use mixed methods research to really truly identify the norms that are misperceived and which norms matter, and which, for example, peer reference groups matter. Should we be talking about folks at the village level, in a social network, what matters? And then there's methodological innovations around using some causal methodologies and taking into account network effects, and perhaps collecting biomarker data, for example, that would really help us nail down what the true norms are. And then can we combine messaging around, for example, these related health risk behaviors around alcohol use, around HIV, perhaps around intimate partner violence, and a couple other topics to really help sort of support the idea that these holistic interdisciplinary behaviors, these positive behaviors actually exist sort of in large swath across communities. Let's think about designing some novel strategy designs, particularly in places where there hasn't been a lot of social norm approaches and strategies done. So are there certain ways to communicate these things in places that have perhaps less infrastructure? And can we partner with traditional healers, community health workers, and others to spread these actual positive norm messages? And then I think there's a novel area that could be really interesting, taking some ideas from implementation science and research, taking what we've learned about how to use and implement some of these strategies in school settings and clinics and other spaces, and then how can we adapt that to places in low and middle income countries that represent HIV endemic context, to thinking about, well, how can we use what we've learned in terms of these effective strategies and to address misperceived norms and ultimately increase HIV prevention uptake in these other settings. And I think this could be a really interesting question to address too around HIV vaccine uptake when and here that's ready, and we can help perhaps support that in advance by thinking about do people misperceive norms around HIV vaccine uptake? We found that they have around COVID vaccine uptake. And so how can we begin to think about incorporating positive social norms as we begin to build toward the need for HIV vaccine uptake across these HIV endemic regions? So that's a lot I've shared with you today. Hopefully some of this has resonated with you in some way. Please feel free to reach out to me. I'd love to talk more about it. And ultimately, I do have to say thank you to all of my collaborators, study participants, co-investigators, mentors who I've had along the way. I really appreciate all the support and challenging questions that you've brought to me along the way. And I look forward to continuing this line of investigation. At this point, I'd open it up for questions.
Thank you, Dr. Perkins, very much for that presentation. We can move right into the questions. So there are many outcomes that are studied in public health research, including behaviors, self-efficacy, norms, attitudes, and so forth. Why have you chosen to focus on norms in particular?
Sure, so that's a great question. I think some of that is I've always been fascinated by interpersonal interactions, conversations, and this idea of we don't live alone. While some of us might think we live alone a lot of the time, we live in concert with human beings. We are social animals. We've evolved to be that way. And I think that we see these norms arise all the time. We see them in conversations between parents and children. Children are like, well, I want to do this because all of my friends are doing that. And it begs the question of, well, are all your friends actually doing that or not? Where do these perceptions arise? And I have to say that I think there's opportunities for assessing norms and the way that these other factors we know that are important, self-efficacy, attitudes, how do they relate to norms? So I would never say that addressing social norms is like a silver bullet, that it should be done in isolation and not thinking about these other really critically important factors. But I think often we don't take into account norms when we're thinking about these other factors. And there's some really interesting areas for looking at the intersection of those kinds of attitudes and self-efficacy and other issues, and how do they moderate or mediate some of the norming effects that we see.
How do we tailor strategies to change perceived norms for a particular population? Will the strategies vary from population to population? For example, rural Uganda versus rural Tennessee?
That's a great question. So I think that's a fascinating area of exploration that should be addressed. So I think that while there are some universal phenomena that we see, so for example, misperceived norms tend to exist in most populations and places, and that they do seem to matter for health outcomes. I think that there's probably other factors that may increase or reduce or moderate or mediate the effectiveness, for example, of different strategies that are associated with culture, that may be associated with infrastructure that's available, that may be associated with the different technologies that people are using in these spaces. And so I think that any time that we are going to do some of this research, it is important to step back and say, well, how do we know what the norms are in these places? And what are some factors, some like larger, let's think about the socio-ecological framework. What are some other factors that might be important here in this context? And so stepping back and say, let's do some qualitative exploratory work ahead of time to really kind of map out who are the important network peer reference groups, what are the laws and policies in each of these places, are there some social customs that matter, are there gender differences that matter? And so really trying to map that out so that you're not just taking an intervention from one place and plopping it into another, because I think ultimately it won't be as effective as you'd hoped. And so it's really important to do some of that background work and thinking around what are some of the factors that matter in each of these contexts that might interact with how norms are created and perceived, and then with how we might go about changing them.
One of our audience members asks, kindly identify the cultural barriers that might have existed during the study in Uganda and how you adapted the study to improve the outcomes and perceived norms concerning HIV.
So that's a great question. So so we've been collecting this data and working in Uganda since about 2010. And the way we went about working in collaboration in Uganda is we partnered very closely with MRI University of Science and Technology and with local leaders to first sort of see what were some of the behaviors and sort of a general idea of social norms, these general unspoken rules in these communities, and what were the issues and topics and behaviors that people wanted to learn more about in terms of what was going on in their villages. And so there were a number of things highlighted around HIV, alcohol use, intimate partner violence. And so the topics that we ended up studying were really driven by their suggestions and interest in what they wanted to learn about their communities. And at the time, in these communities, there weren't a lot of local provision of HIV prevention and treatment services. And there still isn't. Folks need to travel about 20 kilometers to go get treatment if they are living with HIV. There's not a lot of options for alcohol misuse or intimate partner violence in terms of getting treatment or access to support. There's more and more mobile HIV testing interventions that are coming through, which it's actually been really interesting because despite that those are coming through, and indeed our project has offered that as well, people still think that getting tested for HIV is not very common. Now, there's ultimately larger sort of national policy changes that have been going on too. And so that certainly is, we know from some research in the States and other places that when there are policy and law changes, they do contribute to how people perceive social norms. And so that's something for us to consider as we continue to collect our data over time. What are some of the larger sort of district and then national level policies that might be contributing to people's perceptions? And it's certainly something that we should be documenting as we collect data over time.
Somewhat related to that, does rampant misinformation on social media or other media and related mistrust among consumers of information undermine the impact of norms messaging? If so, how can this be mitigated?
Yeah, that's a really great point. So a lot of what contributes to folks' misperceptions, or one piece of what contributes to folks' misperceptions is what they see on social media. And we know from some research that what around alcohol use, for example, what people see on their Instagram accounts or Facebook, wherever it might be, or ads, that does matter in terms of contributing to people's perceptions. We would hope that these kinds of local strategies that really dig into articulating what are the local norms in these communities, in these social networks, or in these districts can help to combat some of that misinformation. Because we know that people's perceptions of what is happening out there in the world matter, but sometimes and often what tends to be even stronger in terms of what predicts their own behavior is what they perceive to be the very local norms. And so we argue that there's a way to think about defining what the local norms are and sharing them at clinics, at local schools, in local community group meetings, and how that might help to combat some of that misinformation. At the same time, I would argue that combating that kind of misinformation or conducting kind of this positive messaging, social norms messaging, it's not a one-shot deal. Like putting a one message out there, hey, most people in your community have been tested for HIV. That's not going to cut it. These are the kind of conversations and messages that we need to continue to think about. Well, how can we continuously ingrain some of these messages into our programming over time?
Could you please speak to the impact of norming with Uganda's political stance on homosexuality or pulpit speeches to populations?
Yeah. So certainly the changes in Uganda's laws are going to have some effects on what people perceive to be normative. They're going to have some effects on stigma associated with certain populations, and then ultimately sort of the fear that's going to rise in terms of accessing care and getting tested and things like that. I think part of the work that could potentially be done in this space is to collect people's personal attitudes and beliefs about what they support, what they think is okay, what they think is, whether they would stigmatize certain populations or not, and then begin to think about, well, what do people personally think, and what are the local social norms around that, and are those in contrast in part to what the national laws sort of are dictating? And then can we begin to think about, are there ways to talk about local support for a variety of populations and communities within the country, and not just sort of assume that these laws dictate everyone's opinions, but that often what happens at the national level may not represent what are the positive local norms within communities. And so I think there's an opportunity to assess what are the local attitudinal norms towards many of these topics that are quite controversial.
You said that messages should be positive, inclusive, empowering, credible, local, and sufficient. Which of those elements are most important? And how do you make a message credible, for example, or inclusive?
That's a really good point. Okay, so I think, well, first and foremost, the positive aspect, I mean, that's kind of the overarching idea. You flip the statistic instead of saying, 15% of people in this community are engaging in this negative behavior, and 85% of people are not. So that, but beyond that, I think, well, this is a question that research attests, which one of these characteristics is the most important. But from what we know is that people really need to be able to believe these statistics, believe these data. So having it based on credible data and having lines or, spoken about where the data are coming from. So, this statistic comes from the data that we collected last year, or that we talked with you all about in our last group session, something like that. I think that's really important. And, data can come from local populations or studies that are being done. There's also a variety of sources of publicly available data that can lend themselves to creating these positive norm statistics. So if something isn't available at the local level and there are no options or ways or resources to collect that data, I encourage folks to think about, well, what's the next level up? Is there district level data that's available? Is there national level data that could be tailored to certain regions? And so I do think that tying these messages to a credible source is helpful in getting people to believe it. I should say that when people first see these statistics, a lot of times they're like, no way, that's not true. And then people start to panic and think, oh, this kind of strategy isn't going to work. But that's the whole, like, hang in there for a little bit. That skepticism is a good thing. One, it means they saw the message. And two, they're turning it around in their brain, perhaps unconsciously. And so that the more they see those messages and the more they have some of those conversations, it creates this cognitive dissonance process that ultimately begins to shift their perceptions over time. And so having credible data and being able to name where it comes from as part of that conversation is really important.
Dr. Perkins, I want to thank you for a wonderful presentation. I want to thank our participants for really interesting questions. As I mentioned earlier, we will be posting the slides and a recording of today's presentation on our website in the next few weeks. I want to thank everyone for joining today's lecture.
Great, thank you.